الزميلات والزملاء والضيوف الكرام، أجدد لقائي الطيب بكم وأسعى بمثابرة لا تهدأ وإرادة لا تتعب وشغف لا ينطفئ إلى إطلاق المؤتمر العلمي السادس لأمراض الجهاز الهضمي. وأجتمع بكم هذه المرة في بيروت التي وصفتها الصحافة العالمية في يوم من الأيام بأنها المدينة الأكثر إثارة على وجه الأرض. أجتمع بكم في بيروت مدينة الإشعاع والإبداع، والتي أصبحت مدينة الأوجاع والرعاع. في بيروت التي انقلبت من سيدة التاريخ إلى شهيدة الطوائف. أيها الزملاء القادمون من وراء البحار ومن مختلف الدول العربية ودول الجوار ومن جميع أنحاء العالم، أيها الآتون بعزم المحاربين وشدتهم وتصميمهم، المشبعون بالشغف العلمي وحب الابتكار والإبداع، أنتم المؤتمنون على صحة الأبناء والأهل والأوطان، تحملون في حقائبكم الآمال والأحلام والوعود لتخليص الإنسانية من آلامها. أرحب بكم أجمل ترحيب وأجل رسالة العلم التي تحملونها من أجل سلامة الإنسان، وسيوف المعرفة التي تشهرونها عالياً من أجل قاطع دابر الأمراض والأوبئة في كل زمان ومكان. إن حضوركم هذا أيها الزملاء الكرام هو الرافع المهم والفاعل في تطوير الطب وتحسينه والوصول به إلى أعلى درجات الرقي والتقدم والإبداع، وهو السبب في نجاح المؤتمرات التي نظمناها في السنوات الماضية. وها أنتم اليوم تجددون التزامكم بالحضور والمشاركة الفاعلة، وتدافعون عن مواقعكم بقوة وتصميم، وتصمون آذانكم عن المتربصين شراً بالبلاد والعباد، لأنكم شعوب تحب الحياة وتنبذ الجهل وتستميت في رفع القيم الإنسانية إلى مداركها العالية. ومجدداً من مستشفى النجدة الشعبية المعطاء في النبطية أعلن افتتاح المؤتمر السادس للجهاز الهضمي، شاكراً كرم حضوركم للمساهمة في تفعيله. زميلاتي، زملائي، أيها الحضور الكريم،
Good morning and bonjour.
Good morning, I'm Dr. Ali Farag. Helping me, Dr. Mahmoud Hilal.
Hi everyone, it's a pleasure to be here. Pleasure to be assisted by Dr. Shaima.
Good afternoon, everyone. My name is Vikesh Singh.
Good morning all. So we will start with the first case in LIVE1. So this is a 57 years old male patient, previously healthy. He presented with jaundice, and on the MRCP it showed Klatskin tumor type 4 that was confirmed by EUS. So this is the filling defect here. So this is the EUS FMB for the Klatskin tumor. We took FMB and it showed a 3 centimeter hypoechoic mass in the hilum invading the portal vein, 360-degree encasement, and the bilateral hepatic arteries. This is the hepatic artery and this is the portal vein. And also the biopsy confirmed cholangiocarcinoma. CT scan of the abdomen confirmed also the results. It showed a non-resectable Klatskin tumor with non-reconstructible artery. So we did an ERCP to drain the biliary system. We just been able to drain the right hepatic duct, the right anterior and the right posterior divisions of the right hepatic duct using metallic uncovered stents, 8 mm, 8 cm, and 8 mm, 10 cm. And the bilirubin went down to 2.6. So today we want to drain the left biliary tree, so we will do EUS-guided hepaticogastrostomy by Dr. Mark Barté and Dr. Ali Khalil.
Hello. So good to be with you. Thank you for welcoming me and for inviting me. So I'm working with Ali.
Hello,
He's
good morning.
very famous. So he's also my friend and the nurse. Okay. So thank you to be with me. So we are facing with a patient with excluded left lobe in the case of hilar cholangiocarcinoma. So we are going to do a combined procedure. I mean, he underwent already USCP. Now he is going to underwent BLH. I've used the image, US image. So this is a bile duct, okay? You have the US image? I don't know. And you see, the most important point is to be sure this is not the portal vein. So you put some Doppler. You see, you have the sushepatic vein and you have the bile duct, okay? Okay, so now we know where we have to put the needle. And the second point at US image is to follow the intrahepatic bile duct and to be sure you are going in the direction of the hilum of the liver and not in the direction of the periphery of the liver. So you see, I will try to follow by rotating the scope, and you see now we go to the hilum of the liver, okay? So this is a good direction. This is really dilated intrahepatic bile duct, and then you check at X-ray. Do you have the image of X-ray? Okay, so you see we have into the stomach usually at 45 centimeter, alongside the lesser curve, and you see the orientation to the left lobe, and you see not with too much angulation, because if you have too much angulation, it will be difficult to work. You agree, Ali?
Of course, yeah.
So now I'm going to use a 19 gauge needle, and the goal is first to introduce the tip of the needle inside the intrahepatic bile duct. Okay, so I'm screwing the 19 gauge needle, okay, and then I'm trying to push it. I don't know what is happening. So I release the wheel. I don't know what is happening, but the needle is not going out. No, don't do that, no. So maybe we have something in the operating channel blocking the, okay, okay, so I know what you are going to do. I retrieve the needle, give me some saline, because if you push too much, you have the risk of damaging the needle. So I will put some saline into the operating channel. Okay, give me again the needle, please. Please. Okay. So I'm working with the EUS scope from Fuji. Okay. And now, okay. And now you see maybe the sheath, the sheath, okay, outside. So if you have any resistance, don't push too much. You will damage the needle. So you flush with some saline, and after again you try to take back your position to the lever. Okay. Now we see clearly the sheath. Okay, is too much out. So I pull back a little bit. Okay. And now it's okay. And now what I have to do is to take again my position in front of the bile duct. Okay, you can see it now again. But you see, as I have the needle inside. Okay, so the elevator is not working so much. Yeah, the elevator is not working a lot, huh? Okay, so you see, I try to direct the needle in the direction, but you see, I cannot direct very well because the elevator is not working a lot. So, okay. Okay, so normally, wait, just a little bit. Okay, normally you see, I have just to check the tip of the needle is inside. Okay, now I'm clearly inside, you see, I'm free. I cannot do anything with the elevator. The elevator is not working, so pull back the stylet. No, out. Okay, you tried. Okay. And now we are going to inject some contrast. Okay, go. You have X-ray image? Yeah. Inject, please. You see the bubble filling the bile duct, and you see the X-ray nicely showing the dilated intrahepatic bile duct and going inside the stent. Okay, stop. Okay, you remove the syringe, and now you rinse with some saline. You rinse always with some saline, just a few milliliters, yeah. Okay, it's okay. Retrieve the syringe and give me the guide wire, please. You have always to rinse with saline because if you let some contrast in the needle, it will stuck the guide wire. Okay. So in this case, the difficulty is due to the scope because the elevator is not working a lot, so it's difficult to find the good position. Okay, so now we are pushing the guide wire. Okay. Wait. Okay, push. No, slowly, please. No. Wait. Stop. No, not back. I will do by myself because if you are pulling back too. Okay. So you see, I have some difficulties to push the guide wire in the good position. So I try to change a little bit my position. I am going back, yeah? You see, because I wanted to put more deep. Okay, excellent. And now it's better, okay? Bravo. Okay? How I did that? Only by changing the rotation of the scope, okay? Okay, so now the guide wire is nearly in a good position, okay? Okay, so now the second step will be to retrieve the needle, letting in place the guide wire, and we will push over the guide wire the 6 French cystostom, okay? Okay, so now I pull back gently. No, don't do that. I prefer to do it by myself because you see it's a very critical time, okay? Okay, so you see I retrieve the needle, okay? Okay, now I unscrew the needle and you will push gently the guide wire. Okay, push it. And now you see I put my elevator to block the guide wire. Push. push, 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 push more, more, okay, push more, okay, stop, okay. So now I have the guide wire, so retrieve completely the needle, okay, and I will put again, I need to put again the valve. You see the valve? You have to put it on the guide wire, please. Sir, s'il te plaît, tu peux mettre la valve sur... Voilà. Ben, ouvre-la avec quelque chose.
Needle. Do you have needle?
Ne casse pas le guide. Hein. Okay. Il faut ouvrir la valve. Okay? So this is a very important point to put again the valve, because at the end you will have the endoscopic part of the procedure. We do EUS, we did X-ray, and after, okay, I check just my X-ray position. You see no change, okay. And now we are going to introduce what we call the 6 French cystostom. This is a cystostom with a diathermic ring for making the hole. You put some saline inside. Yeah.
You can move to another room.
Yeah.
And then come back.
And yes, then you come back. Okay.
Okay, you can.
So you saw the main part. The main part is the access to the intrahepatic bile duct with a needle, contrast, guide wire. Now we are going to dilate with the 6 French cystostom, and after I think you will come back for the insertion of the stent. Okay? Thank you very much.
The wire is not going inside.
Yes, of course the wire is going inside.
It's not going inside.
No, this is I bring myself. Well, so this is.
This is the one you bring.
Okay, you can change now. Okay.
Good morning. Our second case for today is a 35 years old patient with a past surgical history of mini bypass 10 years ago. She presented to us with dysphagia since 3 years. Gastroscopy was done and it showed dilated esophagus that contains retained food, lower esophageal sphincter at 40 centimeter with functional stenosis of the EG junction with a small gastric pouch, as we see in the video. So upper GI series was done and showed a persistently narrowed region at the lower esophageal sphincter with a dilated esophagus above the narrowed region. So manometry showed type 2 achalasia. Decision was made to do a poem that will be done by Dr. Mu'in Khashab and Dr. Ammar Ghazali.
Hi, everyone. I want to introduce the team. I have Dr. Katie Norgard, who's coming from Johns Hopkins, and she's assisting with the anesthesia. And Dr. Ghazali, that everybody knows, and Bayoum is here, so that's good. So we're ready. So if you have the endoscopy image, this is a patient with achalasia, and you see a dilated esophagus, and we see the spine here. When the esophagus dilates, we see the spine impression on the esophagus. Where you see the fluid pooling, it's the posterior part of the esophagus. And you see here, we're turning, so it is a little bit sigmoid. And this is the lower esophageal sphincter. So let's have the injection ready, Bayumi. And this is the stomach, and the patient has had a bypass. And we see the gastrojejunostomy here. This will not affect the poem. So if a patient has had sleeve or bypass, we don't worry too much about it. It does not affect the bone. So here I'm going to go anterior, and we're going to inject. And I'm using a Fuji scope with a soft Olympus cap. And this is a regular injection needle. And we're going to do a submucosal injection, followed by incision and entry to the tunnel. So let's get the needle out, please, and inject slowly.
And what are you using for an
This is just saline and methylene blue. Do you have methylene blue in this? Yeah. Okay, hold on. Yeah, just the whole thing, please. Just inject 10 cc. Stop. Inject again. The whole thing, the whole thing. Okay, good. So now we're gonna get the triangular tip knife, and let's make it quick because this is just saline. So we're using the TT knife, and we're gonna go with endocut Q current for the incision. So you may just straighten this, please. And let's put the knife out. Okay. So if you're used to Olympus scopes, this will be just a little different because it comes out at a weird angle here, little blind, but it's okay. Okay, now we're in. We're gonna make a longitudinal incision here. Yeah, keep it out. So
how long do you typically like to make your incision?
About 1.5 centimeters. Okay, so here we can go a little back on the knife. Okay. And now out. Yeah. See, there we have muscle already there, so you have to be careful. Just gonna extend it a little bit here. Okay. So now we're gonna do something called trimming, which means working from, so here the injection is really gone. So what we're gonna do is you're gonna give me back the needle, and we're gonna re-inject. So you see here, you see some submucosal fibers, but just the muscle is right there. So, and you see it's actually pretty thick. So we're gonna just inject a little bit more. And this happens in these patients with kind of advanced achalasia, sigmoid. So another 10 cc. And let's inject first without putting the needle out, okay? So let's just do the, like a kind of a blunt type of injection. Okay. Go ahead, inject here. Yeah. Inject. The whole thing. Okay, stop. Let's see how it looks. All right. It's gonna be a tough case to start with. Put the needle out now, and inject. Yep. Okay, stop. Let's get back the knife. So you have to work it out now slowly and get in. So now what we're gonna do is work on the edges. So so what holds the incision together is this submucosal fibers that attach to the mucosa. So once you cut these fibers, the incision opens up. So that's called trimming. We're going to trim the submucosa.
To avoid having to cut more mucosa.
It's not about the length now of the incision. It's just one of these tough, out please. So you see here, I'm focusing, yeah? It's okay, yeah. We'll be in when you come back. So you guys are going to another room, and we'll see you when we're back, and we'll show you some tunneling.
So what we did, okay, after over the guide wire, we need a dilatation with the 6 French cystostom with pure cut current. And after we retrieve the cystostom, and then we inserted the stent, which is a dual-bore stent from Taewong, meaning that 1/3 of the distal tip of the stent is uncovered, and the remaining stent is covered. Why? Uncovered to drain all the intrahepatic bile duct branch, and covered to avoid any biliary leakage between the liver and the stomach. So if you have the X-ray, you need now to have the endoscopic and X-ray image. So you are going to release, so unscrew there.
So Mark, you prefer releasing the stent endoscopically with the
exactly.
endoscopic view?
Yeah, exactly. Okay, so X-ray all the time, so release. Release. Okay, you see the distal tip is opening. Okay, release. Release. No, it's not working. We have a trouble. Release.
Yeah.
No, so now it's opening. Okay, you see? Okay, release again, gently. We do that gently. Release again. Release, 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 release. You can do that. Release. And when you reach the marker, it means that you are not able to recapture the stent.
On a return point.
Yeah.
On a return point.
Release again, again, and now we work again, please, again. Wait just a minute. I just adjust my endoscopic position. Okay. Okay, release again. Release completely now. Release completely. Release. Okay, and now it's done. Okay? So now it's finished. Okay, so if you are not sure about the quality of your biliary drainage, you can let in place the guide wire and inject everything. So, but I'm sure you see clearly the guide wire inside the close to the stent, inserted by a USCP approach. You can see clearly the distal tip, which is inside the left hepatic duct, and you can see also the stent crossing the liver and the gastric wall on X-ray and endoscopic. So I retrieve everything, okay, and it's okay. Okay, and now you see the bile flowing and some pus also.
Yeah.
Okay, so it's done. It's okay. Thank you. Thank you. And on tomorrow, on Saturday, I will have a lecture about endoscopic management of hilar cholangiocarcinoma, and I will speak about the combined procedure, meaning stent in the right hepatic duct with USCP and stent on the left hepatic duct with EUS approach. So I will speak about it tomorrow. Thank you very much for your attention, and thank you to all my team. Okay, thank you, and congratulations to the anesthesiologist. Just you see the patient is intubated on supine position, and we're working with CO2 insufflation. This is finished, okay?
Our third case for today is a 69 years old male patient with a past medical history of hypertension. Gastroscopy was done in May 2022 for recurrent epigastric pain that showed a 1.5 gastric polyp in the fundus that was resected using ASD. CT showed no metastasis. The pathology revealed a neuroendocrine tumor G2 with the index Ki 67 10%. The lateral mucosal and submucosal surgical margins are free of tumor invasion. This is the first ASD. So in the follow-up, in August 2023, it showed a recurrence of the fundic polypoid lesion. So decision was made to do ASD for gastric neuroendocrine tumor by Dr. Pradeep and Dr. Asma Al-Kandari.
Hi everyone, good morning. I'm really delighted to be here on a sunny morning. I wish I was on the beach, but we are here in Zahir's unit. Thanks Zahir for inviting. Asma is with us. We're evaluating this lesion who's had previous resection for carcinoid tumor, or well, we should not use the term carcinoid, it's called neuroendocrine tumor. So Asma is just showing you where the previous resection was performed, and now there's a recurrence here. So if you change, let's stick with the white light, and you can see a scar, and then there is a reddish hue in the middle. We've just done some marking around it. So if you go back up to it, Asma, and change over to LCI. So if you change to LCI, you can see the lesion much better. Here is the lesion. Keep going. Yeah. Unfortunately, there's a lot of food. This patient has recently started taking Ozempic, and Zahir didn't know. So he's developed gastric stasis, and there's a lot of food around, so it's very difficult to show you exactly what's going on. Just suck that. Yeah, that's it. Stop. Let's stop. But you can see on LCI that there is a lesion in the middle, which is on the, and the base is scarred because of previous ESD. I think it's considered as a recurrence, but I think it could be because there was another little carcinoid close to the scar, which is now grown up. So various things here to talk about apart from the food. First is, to me, it appears like a type 1 carcinoid.
Yeah, can you tell us about the type of carcinoid for this?
So this looks like type 1 to me, because what you're showing now is, just go back there, up, no, come back. This looks like a very atrophic stomach. Look at that. So there is chronic atrophic gastritis, and that's when you get type 1 carcinoids. They develop on a background of chronic atrophic gastritis. About 70 to 80% of the carcinoids we see are type 1. And typically, you see chronic atrophic gastritis. If you measure the gastrin level, you'll get very high gastrin in them. And they generally don't. So if you have high gastrin, you can either get type 1 or type 2. With type 1, you will not have MEN or other gastrinomas. With type 2, generally they have an associated MEN syndrome. So that's why, and they are very rare. So this is type 1. In type 3, which is the most risky carcinoid, there you don't have, the gastrin level is completely normal, no atrophic gastritis. So this is not type 3. Now, if you look at this stomach carefully, generally you'll find a lot of other carcinoids. So can you demonstrate other lesions here? There. So there we go. We got another second lesion there.
With the white light.
Yeah, if you go close to it and change over to LCI, you'll see a yellowish hue. Yeah, you see on LCI, the center area looks red, and then little yellowness around it, and that's classical feature of carcinoids. The other thing to note is that if you go to, yeah, so another one there, a flat carcinoid, then another nodular one. So there are multiple little neuroendocrine tumors scattered all around the stomach. If we didn't have the food, we probably would find more lesions in this stomach. But to me, the most important thing in these patients is to look for early gastric cancer, because they don't die of neuroendocrine tumors, but on a background of chronic atrophic gastritis. No more? Okay, so I've just been told that even without the food, they've evaluated very well. These are the only 3 lesions. So we can potentially clear all these. They're all small, but if you go by recommendation and guideline, if they are less than 1 centimeter, you don't need to do anything. Yeah, so you can do surveillance. Between 1 and 2 centimeter, usually I would recommend we resect them. If they're more than 2 centimeter, then the risk of metastasis goes up. So generally, we would not resect. So you get showing another one, and that's the central umbilication that you see, or ulceration, another classical feature. But the surface pattern and vessel pattern will look completely normal. So if you use BLI and show the surface pattern of this lesion, you'll find it's exactly the same as the surrounding stomach. Only difference is it's a bit dilated. So that's why I feel they are submucosal tumors, and they grow quite deep, and that's why the only way to remove them will be either ESD or FTRD. Please do not attempt EMR. You'll always get R1 if you do EMR in them. So that's just a little umbilication where you have a little bit of food stuck in there. So I think the lesion that really needs resection is the one that we marked. Unfortunately, because of all this food, I don't think it's recommended to resect at this stage, because second issue with carcinoids is that they bleed a lot. They are very vascular. Stomach is very atrophic, so it bleeds. And if we get a bleed and we suck the blood, the food will come racing towards the lesion.
As you can see.
Yeah, you can see a little bit of suction, and now the food comes very close to the lesion. So I don't think this is ideal setting for resection. Maybe we wake this patient up, and as my colleague said, we make him vomit. If he can bring all this food out, we'll go back in around 4 o'clock and resect it. But otherwise, in this setting, I don't think it's a very good idea. I'm not sure if there's any question from our audience, but we can't hear them. Sir? Oh, okay. But there is no speaker in the room, so I don't think we can hear them. No?
I don't think it's a good idea to...
No. I think you're right. We just wake him up and he put finger in his mouth.
Yeah, yeah.
Oh, we are live.
They said they don't have erythromycin.
Okay, we are live. But can we turn the speaker on so we can hear them? If there are any questions from that side. Rather than just me giving a monologue, it's good to have a discussion.
I want to ask you, Pradeep, about the specimen after resection. How do you know that we reach R0 resection?
It's very difficult to know, but the important things is with carcinoids, they go very deep in the submucosa. So when you're doing the resection, you have to stay very close to the muscle. So unlike gastric cancer, we will stay away from the muscle. Here you go very close to the muscle. So I almost always use traction technique here so that we stay close to the muscle. But if you look at the literature, the R0 rate for carcinoid is very low because they go deep into the submucosa and people tend not to go close to the muscle, and that's why they get very poor R0 rate. So it's okay.
And also,
yeah. That's fine. But, so,
Like suction, cup, EMR,
like
banded.
band EMR? In stomach, no. In rectum, you could try, but in stomach, the wall is quite thick, and once you put your band on, and as you inflate the stomach to see, it will slip, and you'll cut it very superficially, so you'll get R1. No. Don't do anything. Leave them. They don't do any harm. But when they will grow and you've done APC, we screwed then. So best is not to resect. Most type 1 carcinoids, they are...
We didn't say that we don't resect if it's less than 1 centimeter.
Yeah,
we have to say that. We haven't said. We haven't said it.
No. I discussed that. There's no need. Less than 1, you can just do surveillance.
This is a tough case with extensive submucosal fibrosis. You see here when we trying to get into the tunnel, we go straight to the muscle. So we're going to see how we can work this out. I'm going to take back the injection. And the good thing here is that we are very distal. So when you have a tough case, you're going to go distal, just a few centimeters above the GE junction, and just work with it and see if we can get even a thin layer of submucosa. So I'm going to re-inject here, and hopefully we'll be able to do something. So this is an advanced achalasia case. So in a way, it's good, so you guys can see how we handle these tough cases. Typically, eventually, it works out, but you have to try multiple locations. So here, the reason for bleeding, Ammar, is that when you make the incision, you're going deep because down to the muscle. That's why basically you hit bigger vessels.
Yeah, you're bound to.
Okay. Bayumi, you're here with me? Yeah. Okay, hold on, not yet. Okay, go ahead and inject like that without a needle. Just inject, yeah. Inject? Yeah. Inject? Yeah. Now put the needle out and inject. Yeah. Okay, no, that's good. And then let's get back the knife, please.
So when you're trying to get in now like this, would you consider cutting the mucosa a little bit more, or would it give you any more leeway, or not really?
I mean, possibly I will, but you know, if you end up, the one thing you don't want is to keep cutting the mucosa.
And then you have nothing under it.
Yeah, you have nothing under it. So let's, I mean, here just some patients I think will be good, and we'll get in, but it's, you just have to accept that some cases are like that, and it's going to be tough getting in. So here, although it's posterior, I'm turning the scope to make it more anterior and approach, like to get in, and hopefully that will help. So now on my scope, I turned it 180 degrees. And let's see if we can try to get in like that. Give me the knife, Ayumi, so that if I have an opportunity to do some trimming, I will do some trimming to help get in. Any questions from the panel? Can we hear their questions? Or just to keep this interactive both ways? Bayumi, please. You're going to have to come closer to me. Okay, so let's get them to ask then.
Mu'in, we have a question here.
Yes.
Hello. Dr. Mu'in, first you choose anterior, now you change to posterior?
Yeah, I could not tunnel because there was no submucosal layer. So I went distal and posterior because distally the esophagus is very dilated, and if you go anterior, what ends up happening, you will retroflex in the esophagus. So
What we know that, Dr. Ma'in, for advanced sigmoid esophagus like your case,
yeah,
it's preferable to do posterior approach.
yep, I agree with you. So that's why we're doing posterior. But I mean, posterior approach if you go distally. If you go proximally, it doesn't matter. So we tried to do an proximal, it didn't work. I'm struggling a little bit also with the scope because I'm not used to the Fuji scope. It's excellent in terms of visibility and maneuverability, but where the knife comes out, it's a problem for me. But we'll see. Okay, so this is the incision here. Let's see if we can just squeeze ourselves in here a little bit. So here I have something to work with. This little here, what is this in? Okay, out, good. So this is a little bit of MM here. The small maneuvers, just some fluid. We see a thin layer of submucosa there. Can you guys see it?
Down at 6 o'clock.
Yeah, starting to see something here.
Mm-hmm.
But it's still very thin and not great. See here, the muscle is just folding on itself.
Mm-hmm.
Yeah, it's a tough one. Okay, let's see if we can do some cutting here. I'm gonna use the endo cut. So here, just slow cutting until I get more space, and then we'll get in. Okay. I mean, we
slowly.
went on a second side, but you see, it's this is all the submucosal layer we see. So it's very tough, but we'll get it. So you didn't give me an easy case there, let's say that. But this lady probably has had symptoms for a long, long time.
Mu'in,
Yeah.
how often you find this kind of fibrosis in achalasia patient?
How often?
Yes.
Yeah, so it's very common in advanced achalasia to have these tough cases like this. Ordinary achalasia without prior treatment, really not common. But I think now we're good. We have some layer to work with, you see here. Mm-hmm. So now what I'm going to do is I'm going to turn my scope to get into a natural position. And now we are good. So now we see a normal tunnel finally. Mm-hmm. This is the first time we see a Bayumi. Is there a way for you to do, like, come from like this side or something? I know it's hard, but if anybody can do it, it's Bayumi. So now we're going to start just tunneling here. And as usual, we always talk about it, how it's important to tunnel on the surface of the muscle so that we maintain the mucosa intact. So I'm using a spray coag here. I think it just makes the procedure faster. So now we are moving towards the LES. I inject through the scope a little bit here to ensure that the submucosa is hey guys, this is still not working well. The spray part, it's like all over the place. So I don't know what's going on with the machine or what it is, but this is not a normal spray. Huh? Switch to, huh?
To tunneling?
No. I have it on spray. And this is exactly the setting I use, but it's not translating into. What is the water we're using? Saline or the fluid or water? Huh? Saline. Yeah. Okay. Can we go up to maybe 50 watts on this? Maybe see that. Yeah. Okay.
Go ahead.
So I see this sometimes when you travel to other centers, the settings that you use don't translate. The room is, yep, keep it like that, please. Huh? That's okay. Here it seems that with Fuji we have to maybe work a little bit little
sideways
or a little far.
Yeah.
Okay, so now we are getting into a tighter area, so we'll see if that's the LES. Any questions from the panel? You guys are very, very quiet.
So if you lose your bearings, you sort of move back away to the beginning of the tunnel and sort of reorient yourself.
This is okay. Let's maybe change the knife or something. I don't know what to say, but this is, guys, not cutting. What do you have for me?
The knife.
Huh?
Maybe you can change the knife.
Yeah. Do you have a dual knife or something? But this is not working. I mean, if you this is the quickest knife for poem, and it's not cutting. And when it's cutting, it's not cutting the right way. It's not where it should cut. Out. So you see this? Like nothing is happening. See this? This is a very strong high current density. So and it's doing nothing there. So where is it? So
the patient plate is far from.
Where is it?
Now.
Huh? Guys, please put it here on the trunk. Huh? Our working area is here. We don't put it on the leg. So this is the grounding pad. It should be close to the field.
بس انتبهوا Yeah.
No, maybe this will make it work. حطوها هون على الجنب. على الجنب ايه. مش على الاجر كثير بعيده، هيك لازم نعمل.
كان يفهم على وجهي.
حطينا تحت الاجر.
Yes, yes.
هذا اللي صار معنا.
Yeah.
Okay, so let's see if this fixed it. Yeah.
I have this one.
Yeah, this is not good. Huh? What is this? Yeah, just give me something. I don't know if it's a knife or what it is, but we have an issue. It's not cutting well. Thank you. Zahir is opening up his toy box. Okay. هذه تي تي جي هذا فيك تعمل انجكشن فيها. Okay, let's see if this will work better. Out? We'll see. Maybe. I am not ready to. commit.
Commit to an answer.
Yeah, but it seems to be okay.
Dr. Moeen,
Yep.
how far do you stay away from the LES?
What does that mean? What do you mean far? What do you mean?
So do you go and burn it, or do you stay away from it through your tunnels?
No, we are here to treat the LES. So yeah, this is not right, guys, huh?
Shall I put besides tech mode, maybe?
No, we shouldn't change modes. It's something is wrong with everything else, but not the mode. So to answer the question, so we just have to stay next to the muscle, and it's not staying away from the LES, because when I stay close to the LES, and once we pass it, then afterwards come the myotomy, which is the cutting. Why don't you change the Irby machine, please?
Hey.
Okay. So after we finish tunneling, we're gonna come here and start cutting the muscle. So we start here, cut the LES. We are at the LES, and then continue into the gastric cardia. But I really think we need to figure out the carter issues, especially with the Zenkers coming up.
How far do you go into the cardio?
2 centimeters.
Okay.
So that's key, actually. It's important because the reflux rates are higher if you would perform aggressive cardiomyotomy.
Mm-hmm.
Look, I don't know. I mean, we're changing these, a lot of things.
اسحبي بليز يا ليلى.
نطلع نغير الدعسة كمان كل شيء.
في أي سؤال من البانل while
Dr. Moeen?
Yes.
We just want to know when you cut, while cutting the tunnel, do you use the cut mode, the coag mode, or the blend mode?
So for the incision, we use endocut Q, which is a blend mode, so it alternates between cut coag. For the tunneling, you can use different methods. What I use is a spray. It's like APC, it's fast. But also you can use a swift coag or precise sect for that. For the myotomy, I try to alternate between endocut Q and spray, depending if we have small vessel bleeding or not. But even when you have endocut Q, if you want to use endocut Q for the myotomy, you want to increase the coagulation effect. So your effect probably has to go 3 or 4. Also, the cut interval, you have to increase it, so you get more coagulation. Otherwise, it's going to cause bleeding. So when we talk about endocut Q, also have to talk about the components of endocut Q, because what you can change is how much cut and how much coag, because it's a combo, right? It's a so you have to basically check your cutting settings and coagulation settings when you do endocut Q. So let's see if the Irby is ready now. If you guys want to bring it close to me here to help you with the endo. Okay, let's do this.
مش الحال.
311.
مش الحال. ضوض أخضر.
11.
لا لازم.
Dr. Moeen, we have another question from the audience.
3.5. 311. Play.
Yes, please go ahead while we're fixing this. 40. 40.
Okay.
Okay. Let's see if this works. Are we attached?
Yeah. Yeah.
Mm-hmm.
Cable done, Mark. Okay.
حط رجعها. رجع النايف. Okay, out. In and out. Okay, good. Let's see. Yeah, much better. Okay, it feels normal now. ها؟ ايه بس احسن. It's be like responding to what I want to do. ايه شو السؤال الثاني؟
We have a question from Dr. Najah Zayani saying, is the needle brand new?
The knife brand?
Is the needle brand new?
It's new.
Used before.
The needle.
Which needle? Like the injection needle?
Yeah, the knife, the needle knife.
So no, this is a triangular tip knife. So this is the usual. This is the J. So you can inject through this, but it's not new. This is what this was actually started for poem, and so we've used it since we started doing poem in 2011. So here we have the muscle at 6 o'clock, and we are likely at the LES. So we're gonna continue to tunnel here. So we see the layer. So we see the submucosal fibers here. Whoa. Okay. So not the best delineation of anatomy because it's just a little tough. But it's okay. We'll make it. We're gonna make it work, guys. So you're seeing the muscle down there, right? أي واحدة هذه؟ املي البيضة، هذه الزرقاء. Okay. Good. We see the muscle there. So as long as you see the muscle and you have some mucosal fibers, you're in good shape. So let's come out here, see where we are on the other side. Take this please out. And let's clean it. Yeah, we'll clean it. We see here some coagulation effect from all the burning, but it's fine. Because of the difficult anatomy, huh? But it's good, we don't have any mucosal injury per se. So here, this is at, looks open now. Okay. So again, when we come here to enter, we rotate the scope when you're posterior and then go in. And I think we probably are deep enough there. It's really hard to delineate the anatomy. But here we are at 40. So let's just do maybe an extra centimeter and then we start doing the myotomy. So if you have any, of course you have to look at the mucosa afterwards. If you're worried about Sometimes we see a minor coagulation effect. You don't have to do anything for that. If you see significant coagulation effect, it's good to place clips to avoid delayed perforation of the tunnel. Open, please. Okay, so let's see if this is gonna work. So we're back, huh? We're still struggling here with this, but we haven't really figured out why, huh, Bayumi? Okay, so let's start doing the Ma'armi, and then we'll see how it goes, guys, okay?
Can I have a question, mine?
Yeah, and you can, yeah, so we have 2 minutes. I'm gonna start the Ma'armi so that they see some Ma'armi, but go ahead, please, yes.
Okay. This patient, he has severe fibrosis. Maybe use for creation tunnel, use endocut Q with instead of spray or other coagulation. Better. What do you think?
Yeah, we tried that. I had some bleeding, so I switched. But you're right. That's not a bad idea. And here now with so you see with the Ma'armi, this was endocut. So I tried to switch between both, depending on the response. And obviously here, with the problems we're having, the endocut Q is behaving much better. So, and cleaner, right? The other one is just, it's like everywhere. So, so typically we start with partial thickness and go to full thickness. But since this is a very short tunnel, we just do full thickness right away. Because it's a very short Ammar, so there's no point of...
Yeah, you just need to go...
Okay, so I think you guys are going, are leaving. So this is the Ma'armi. We're going to continue to the end of the tunnel, and then we're going to close the mucosal entry.
زميلاتي زملائي أيها الحضور الكريم
Good morning and bonjour.
Good morning, I'm Dr. Ali Farag. Helping me, Dr. Mahmoud Hilal.
Hi everyone, it's a pleasure to be here. Pleasure to be assisted by Dr. Shaima.
Good afternoon, everyone. My name is Vikesh Singh.